Start? Okay. So, good evening, everyone. I am Dr. Astha Gupta, and I invite you all to yet another exciting session in Innovations in Hematopathology, organized by Fortis Institute of Blood Disorders. And today's topic is basically dealing with the current scenario of utilization of cellular and immunotherapies, which have changed the treatment paradigm. And however, it has brought lot many challenges, the pitfalls, and so many basically challenging scenarios in flow cytometry. And to deal with this challenging scenario, we have got on board Dr. Jean Oak from Stanford University, and she will be talking on basically the cellular and immunotherapy effects and how it helps us to deal with the flow cytometry in the flow cytometry. And she is a clinical associate professor of pathology at Stanford University. Ma'am is a esteemed council member of International Clinical Cytometry Society, and she's a director of clinical flow cytometry lab at Stanford Healthcare and oversees the basic foundation, everything about flow cytometry, starting from designing of the panels to validations and implementation and everything. This is our team at Fortis Hospital, comprising of clinical hematologists, the adult and pediatric, the staff, hematopathologist, molecular hematologist. And on behalf of everyone, I welcome you, ma'am, for this webinar. And I will stop sharing my screen, and you can share your screen, and let's begin then.
Great, thank you for inviting me. Let me just pull that up. All right, I'm gonna have to turn off my camera if that is okay. All right, get that started. Hello, thank you for joining me today. I'm Jean Oak, and today I'll be reviewing immunotherapy and the challenges we face in assessing for residual disease by flow cytometry. As you all know, immunotherapy has really expanded in use and as a field over the past decade or so. Immunotherapeutics is a group of drugs that harness or mimic how the immune system detects and eliminates pathogens. There are several approaches to achieving this mimicry. For example, the first group of classes actually mimicked humoral immunity through humanized monoclonal antibodies such as rituximab or antibody drug conjugates such as brentuximab. In more recent years, we've seen agents that mimic cellular immunotherapy, such as bispecific T-cell engagers, such as blinatumomab, which activate and direct T cells to the target antigens, or CAR T cells, which have engineered T cell receptors that target the protein of interest along and have some co-stimulatory receptors as well. So we'll start off with a case of B-cell lymphoma. This is a 21-year-old with refractory primary B-cell lymphoma. She's failed multiple lines of therapies and got enrolled in a trial for anti-CD19 CAR. This is our pre-infusion PET scan, which showed widespread disease above and below the diaphragm. And the biopsy at that time showed strong expression of CD19 as well as CD22. Her day 28 response actually looked amazing, where it basically seems to have completely wiped out the disease. But unfortunately, this effect did not last because her day 90 PET showed a hot lymph node that looked suspicious for recurrent disease, which got biopsied and confirmed as recurrent lymphoma. But unlike the pre, we now saw that CD19 was lost both by flow cytometry and by IHC. So the initial clinical trial data for using a CAR CD19 CAR T in high-grade B-cell lymphomas looked very promising in terms of a very high response rate. But unfortunately, about 30 to 40% of these patients ended up relapsing. And among those, about 20 to 30% she showed loss of the target antigen. And this effect was largely confirmed in the real world setting. So this is a cohort of patients at our institution who had large B-cell lymphoma and got assessed for a CD19 CAR T. And as you can see on the y-axis, we have the median number of CD19 antigens per cell. And compared to the pre-CAR or the non-CAR T patients, the relapse patients had decreased overall levels of CD19, and a subset actually showed very low levels of that are below 1,000 antigens per cell. And so you might be asking, well, what does that mean? Does that really matter? But before we do that, we kind of want to go back and talk about what are some characteristics, what makes a good target antigen? What are these folks actually looking for? So like all drugs, you want your target to be you want to be specific, right? You want to avoid a toxicity due to destruction of bystander cells. So, and on top of that, and in addition, the antigen actually has to be expressed on the surface. And this is because if you think about how immunotherapeutics work, these all agents all require direct interaction with the antigen. So the target has to be on the surface of the cell. And lastly, you need the signal to be nice and strong. So you need the antigen to be expressed at a high density. And this matters because the density of the antigen seems to directly correlate with the strength of the signal and the response, particularly for cellular therapy-based agents, which can be shown here in an in vitro study where non-6 BALO cell lines with varying levels of CD19 expression was incubated with CD19 CAR T cells, and it also showed that the CD19 CAR activity correlated with the antigen density of the target cells. So with that in mind, let's look at some of the potential targets for high-grade B-cell lymphomas. So here I have a list of 5 antigens that are expressed on the highest proportion in high-grade B-cell lymphomas from a large study out of Europe a while ago. And as you can see, you probably notice that these are on the top 5, not surprisingly, are what we call the pan-B-cell antigens, right? These are 19, 20, 22. These are all the antigens that make a B-cell a B-cell, which sounds great. And we like these. We've been using these for decades to identify B cells. In terms of treatment options now for high-grade B-cell lymphomas, 3 of these already have FDA-approved immunotherapeutics available. 22 is currently undergoing clinical trials, and this basically demonstrates that the conundrum that a good detection antigen has the exact same characteristics of a good target antigen, so they are often the ones that are being prioritized to be targeted. So how does this affect us? Also, to kind of give you an example, this is again this is a lymph node of a patient who had DLBCL and then got treated with CD19 CAR. And if you look, this lymph node shows a prominent large cell population, the forward and side scatter plot, which looks very suspicious. And they look lymphoid based on the 45 and side scatter plot. But when you look at the CD19 versus side scatter plot, you actually don't see anything here, which suggests that, like, oh, maybe there are no B cells, maybe, except that's actually not true, because if you looked at CD20 or CD22, there's plenty of B cells. And unfortunately, this lymphoma actually turned out to be negative for light chains, which meant that if you had a tube that didn't include 20 and 22 and just had 19 and kappa and lambda light chain, you're running the risk of not detecting this population. So to avoid missing things, it is now crucial for your panels to have more than one pan B cell antigens to detect the malignant cells. Here I'm showing you the 2 major B cell panels that we've been running for a while now. And as you can see, both of our tubes have 3 pan B cell markers highlighted in yellow. And you can see, not surprisingly, these are also the immunotherapy markers. And that is by design because we wanted to, one, make sure that if we have multiple pan B cell antigens, we'll get it increases our chance of detection. And then two, we'll be also concurrently be able to assess the expression patterns of these antigens in case the oncologist wants to use them for immunotherapy. And kind of then also going back to the concept of panel designs, uh, when you're now in the dealing with the world of immunotherapy, a lot of the panel design rules that we grew up on don't are need to be kind of bent. For instance, the mantra of panel design is to balance antigen expression levels with fluorochrome brightness to kind of even things out, right? So high density antigens like CD19 or 20 were traditionally paired with a dim fluorochrome, and that's what we used to have. This is our old panel with our old 8-color panel. And when you see that, here's an example of a case that we had where you saw that the 19 seems quite dim. So there's not that great a separation from a background T cell shown in black here. And there's not a lot of 20, but it had a bunch of kappa. And if you display this data as a histogram with and use the background T cells as your negative threshold, you see that about 77% of the lymphoma cells expressed are positive for CD19, and then 28% are positive for CD20. Often we might have reported this as like dim CD19 or like 77% CD19 and then dim or negative CD20, right? But what happens if you change the tactic for your panel design, so you increase the sensitivity of your pan B cell antigen signal by pairing it with, instead of a dim fluorochrome, you use a bright fluorochrome, the data actually changes quite a bit. So this is actually the plots for the exact same case. It was run on the same day, same instrument, but you can see with the difference in the panel design and the increased sensitivity that we got with saturating antibody levels and a brighter fluorochrome, you actually now see a better separation of the CD19 and more expression of CD20. So now if you looked at it by the histogram, you actually see that you would have called this 96% positive for CD19 and like 68%. So both of these would have been clearly called positive for both antigens. So in addition to panel design, it's also important to also design your analysis template to become more a little more comprehensive, a little more forgiving, right? Usually and traditionally for B cells, you want to use CD19 to do your gating, but again, that becomes a problem when you lose CD19. Most of the patients who've lost CD19 usually retain at least one of the pan B cell antigens. So what you want to do instead is to basically want to look at any events that are expressing 19, 20, or 22 and use a combined all B gate. This allows for detection of B cells that might have lost one or more pan B cell antigens without increasing the number of plots that we have to look at, because that no one has time for that, right? So most commercially available softwares will allow you to create a Boolean gate. So here's the Boolean tactic is 19 plus or 20 plus or 22. This will allow you to kind of cut down the number of plots. But now in most patients, as I mentioned, only the target antigen is downregulated at the time of relapse. But that's not always the case, unfortunately. Here is an FNA from a patient with a history of kappa-restricted 510 negative DLBCL who received CD19 CAR T and as well as and before that R-EPOCH. There's clearly, what you can see here on the forward and side scatter plot, there's clearly an increase in large cells. So if you highlight those, unfortunately, you actually don't see that there's actually expression of any B cell antigens, right? It's negative for 19, 20, 22, 79B is even not expressing kappa lambda, right? And we know that the DLB cell before was 510 negative. So this clearly looks abnormal, but we're kind of having trouble getting into the B cell lymphoma camp because it seems to downregulate all B cell antigens. Here's the concurrent cell block. You can clearly see that this looks very suspicious with large cells, and the abnormal cells were positive for PAX5 and CD79A, which kind of again then shows that this is a recurrent large B cell lymphoma with loss of multiple B cell antigens. This can happen occasionally. It's definitely the minor population where you will see this kind of like global loss. We've also seen cases where you may even lose like PAX5, but usually CD79A is generally works probably the best. So if you didn't have it by flow, you could also, or you didn't have the cell block, you could also consider adding on a cytoplasmic CD79A panel to kind of put it into the B cell camp. So to summarize the findings of mature B cell lymphomas, first of all, clinicians will want to know which target antigen is best for the patient. So it is important to kind of describe which trial the patient should be enrolled in, which it means that they pretty much expect to know what 19, 20, and 22 expression will be on all. Flow is the preferred method given the greater sensitivity, and I see if the flow can't be performed. Detection post-therapy requires optimization of the panel design. So if you are on the market to upgrade your panels, you really should be thinking about increasing the sensitivity of these pan B cell antigens. As I mentioned before, with all the losses that are happening with the combinatorial gate is a must. We always do. So for instance, we always do 19, 20, and 22 all B gate for all of our cases. And lastly, because we are losing our routine lineage markers, it is really imperative that you really do learn and pay a lot of attention to the basic 4 side scatter and 45 side scatter gates, which will not be affected by immunotherapy. Let's move on to B lymphoblastic leukemia. Lymphoblastic leukemias is actually where a lot of the CAR T things really started, right? The CD19 CAR success story in pediatric B-ALL was really what drove a lot of the CAR T story off. Unfortunately, similar to B-cell lymphomas, a good number of patients do not have a sustained response, and about anywhere between 10 to 25% of patients, depending on which trial you look at, ended up relapsing with downregulation of CD19 expression levels. So it's the same kind of story. So you're like, how do we manage this? And which antigens are we going to use to counter the loss of CD19? So you probably know CD20 won't work because we can't, it's actually expressed a little too late in terms of B cell development. But what Sindhu et al.'s group at UW used was actually ended up using was CD22 and 24, which are actually expressed earlier on in B cell development and almost around the same time as CD19. So if you made a combinatorial gate that expressed 22 or 24, as you can see here, you can actually recapitulate the 1020 maturation plot that is very similar to what you see with CD19. This gating strategy will not include plasma cells, and you might have some non-B cells here. But overall, the hematogonal maturation pattern is actually very similar, which is very reassuring, and it works pretty well. This is our panel for B-ALL MRD. Again, it's based on the COG panel and Sindhu's panel. But it basically includes 19, 22, and 24 because we have a 12-color instrument. So we have, again, three pan B cell markers that we could use. How does this, how does blinatumomab or anti-CD19 therapy look like? So here's a case, patient got 2 cycles of blinatumomab or CD19 BiTE. And you can see with the CD19 base gating, You can see a fairly decent, 10-20 maturation pattern. Looks pretty normal. I mean, there's not a lot of mature B cells, but it could be early maturation, right? So this is what the 19 base case gating looks like. If you looked at the 22-24 base gating, yeah, there's a little bit of more noise here, but you also see this population right here, right? Like, what is that? So if you highlighted that population, gated that, you actually notice that these are actually 19 negative blasts that was actually buried. One, it was missed by the 19 base gating, and two, it's actually buried within the hematogones. So again, using the 22-24 base gating is actually more important, or although it may also have some caveats that we will discuss a little later. But in terms of pitfalls, so we have, again, another case. This is a patient, 17-year-old with high-risk BALL. You see that the blasts are positive for 10 and 34, little bit of 20. It has decreased 38, has good amount of 22, and then also expresses 24, as well as 19. This patient got blinatumomab and then went into transplant, and most of it looked largely okay, but when we were analyzing this, we saw a bit more of a trail on the CD10 versus 34 plot. So we highlighted that. You can see it might have a little bit of a little fuzzy 20. It's positive for 34. It's positive for 22. And then a lot of it is actually negative for 19. So what could this be? Oh, and we also looked at the concurrent NGS, and the NGS was negative. So we know this isn't leukemia. So what is it? So this population's also been noticed and described in the UW paper, where they are called stage 0 hematogones. So these are CD19 negative, 10 negative, or 10 low populations. They're characterized by expression of bright 22, as you can see here. They're also positive for 34. The 38 levels are actually very similar to normal hematogones. And they oddly can express a little bit of CD20, and then you can also cinch the B cell diagnosis because it'll be positive for 79A. Oddly, they're also a little positive for CD2, but usually we don't run CD2. So this population can trip people up if you're not aware of this entity, and you may be tempted to call this abnormal. Usually you will see this population in the background of normal hematogones, but it is important not to overcall these. In addition to this, now I mentioned before that most BALs are actually negative for CD20 or show very little expression, but there are actually some exceptions. And as you can see in this case, there's actually a decent amount of CD20 expression, and a subset of some hemo that may actually end up using anti-CD20 therapy if there is about 20% or more expression of CD20 on blast, which was actually what happened in this case. So this patient actually ended up getting rituximab. And this can cause issues, particularly in the blood, because what you will see is that all hematogones, which is actually, this is the blood shown here, you're like, oh, that's kind of weird. If you saw this in the blood, you're like, that's not normal. I mean, you can see some hematogones in the blood, but you usually don't see it all just squished up and be completely negative for CD20. And it was very tempting to call this abnormal, but if you notice, if you looked at the other plots and looked at the 38 pattern or the 34 pattern, you would actually have noticed that, oh, it actually has that bright 38 and a little bit of 34. So this is actually, these are actually hematogones. And what you're now seeing is that this actually should have gone all the way out here, but because they have received anti-CD20 therapy, everything got squished up against the y-axis, so it looks abnormal, but it's actually not. And then another potential pitfall, the challenges of being a low MRD is KMT2A. This is probably one of the bane of our existence for BLO-MRD. And there are some problems that can actually also happen in terms of using the 22-24 base gating for detecting this population, because as you can see here, this population is 19 positive, but if you notice, it's 10 negative, 20 negative, and most of the blasts are actually 24 negative. In this case, it might have had a little bit of 22, so that looked okay. But this really kind of becomes problematic because if you had issues with CD19 in this for KMT2A, it can really become problematic for in terms of detection, because you're not going to be able to have a lot of 22 or 24 if you're not careful. And in addition to the usual loss of loss of 24, you can actually have other issues. So here's a patient who got treated with CAR19. We had KMT2A BALO. You can see that there's actually a very prominent blast population, the 45 size scatter plot. So if you gate it on these blasts, you actually see that you're like, oh, okay, I think they're largely blast-ish kind of ish things. They don't have a whole lot of 34, but oddly they're also negative for 10 and 20, and they're also negative for 24 and 22. So being able to catch this population is actually going to be quite difficult unless you actually just went back to the usual blast gating on the 45 size scatter gate. And in these kind of situations, it's also very important to run a myeloid-based tube. So as you can see, the blast population actually has a decent amount of CD19, but there's also it seems to be also gaining some CD15. So there's some variable 15 expression that seems to kind of change with negatively correlate with CD19, and this population seems to be upregulating CD117. They didn't really upregulate 13 or 33, but they are positive for 64 and 4. So it's actually going more towards more of a monocytic differentiation. And this is a known phenomenon for CD19 or KMT2A BALOs patients who have received CD19 CAR T. So in these patients, I actually recommend running both the BALO and AML MRD tubes to make sure that you don't miss this. So to summarize BALO findings, again, the same problems with CD19 based gatings is you can't really rely on that very well anymore. I didn't go over this, but the CD19 antigen downregulation in both BALO and lymphomas is actually long lasting. We actually, for patients who lost it, and had follow-up specimens, we actually haven't seen them recover the 19 expression. So it would be nice if they we're able to give you the history of immunotherapy, but seems like, especially if you're working in a reference laboratory, that may or may not happen. So it's actually safer to actually always kind of include a non-19 base gating, whether usually, so 24, 22 base gating usually works pretty well, but for things like KMT2A and may or BCR or even BCR-ABL, you may actually not have it work as reliably. So next, we'll move on to plasma cell neoplasms. And we will start off with another case. This is a patient with a history of IgG lambda myeloma, and they have received daratumumab or anti-CD38. Here you can see the bone marrow. She still sees a cluster of abnormal plasma cells. You can see that with the 138. And by flow, that's also kind of like what we see. We see the 138 positive population. And it's restricted by lambda. It's apparently positive for 117 and 56, and it's loss of 19. So this was called residual recurrent disease. Interestingly, if you recall, CD138 can be kind of finicky. It needs to be in a brighter fluorochrome, by the way, if you're thinking about developing a plasma cell panel. But usually, plasma cell detection has been more reliant on CD38 expression because plasma cells normally express very bright 38. But in this case, what you can see is that there's actually no CD38 reactivity at all, which doesn't correlate with the presence of plasma cells. So if you were just using 38 base gating, this is going to be a problem. And this is happening partly because of masking due to daratumumab. So here's like, without daratumumab, you have your CD38, and then your anti-CD38 detection antibody is going to bind. And usually in the bone marrow, you'll see this characteristic pattern where you will see monocytes are relatively homogeneously positive for CD38. Lymphocytes, shown in green here, will show more of a smeary pattern. Although if you looked at it versus like 19 versus 38, you'll see like, hematogones, plasma cells, and mature B cells, and then T and NK cells here. So having open gates is actually quite important when you're assessing for plasma cells. This plot is particularly useful because what happens with daratumumab is daratumumab is basically acting like a competitive inhibitor for the detection antibody. So it binds the CD38 and it prevents the detection antibody from binding. So what you're going to end up seeing is that instead of this kind of like, a heterogeneous pattern, you're going to see that there's no reactivity for CD38 at all. And the dead clue is basically if you see loss of CD3 in monocytes, you can pretty reliably say like, oh, there's something going on here. I bet this patient had DARA. So having this open gate available when you're assessing plasma cells is actually quite important. Now, how long does this effect will last? As you recall, daratumumab is an IgG antibody, so it lasts about as like how long you would expect an IgG antibody to last, right? So this is a study from with Elizabeth Corville a few years ago where they looked at CD38 expression relative to the last time period from daratumumab exposure. And based on their patient cohort, it takes about like, this effect seems to last about like, 4 months. And then it eventually starts, the 38 starts coming back. And this becomes, but like, it's like we don't want to wait that long, right? So what are some ways that you can do? Again, there are multiple like other reagents that are available than the monoclonal antibodies for CD38 that you can use. You can use the CD38 multi-epitope, otherwise known as a polyclonal antibody, where you would actually have, instead of one antibody that could be bound or blocked by the daratumumab, you have a cocktail of antibodies that are binding to multiple epitopes of CD38, so you increases your chance of detecting it. Another more recent agent is the JK3 nanobody, which is a camelid antibody. So instead of this whole, the Y-shaped antibody structure, this is actually a smaller molecule that kind of only has like the variable region available, so it can actually slip in and doesn't have as much of the steric hindrance problems as traditional mouse or like rabbit antibodies will have. So these are all options. If you're actually on the market for actually developing the antibody now, you may actually just want to start with the JK36 actually. But if you're also maybe also thinking, well, you know what? I know things on the surface can always be taken away from me. You know what? And I need to fix and perm these cells anyway to look at the plasmic light chain. Why don't I just look at, an intracellular marker instead? And that's, another tactic that's also been used and is actually used quite widely. The two intracellular antigens are used that can be used as VS38C or P63 or IRF4/MUM1. So VS38C is probably much more commonly used than MUM1, although MUM1 everybody in HEMPAT knows because we use it all the time in IHC. You can see that when you use intracellular antigens, you can actually you can actually detect the plasma cells pretty reliably. You may actually get things a little earlier in the maturation pattern than based on 38 and like 138, but it actually is quite useful. And unlike using multiple antigens or other like Boolean gating strategies that we talked about, you could get away with just one set because these are antigens that will not be affected by immunotherapy. with that being the case, BS38C is known to have some issues. So VS30C staining is actually highly dependent on the staining protocol. And two, it also has a lot of granulocytes. So as you can see, Cometry B a few years ago, you can see that the VS30C, depending on whether it was like washed or not, or like which detergent was used, you can actually see more of a smeary pattern if you're not careful. And that's also something that we've also seen in our lab as well, where for instance, this case, you can actually see that the VS38C is not panning out compared to the 138. And you know these are plasma cells because they're all like lambda light chain restricted. So how well your protocol works can be variable. So it may actually be due to, there may be some variability even if you optimize your protocol, but it is something that you need to watch out for. So this is our panel for plasma cell myeloma. You can see here we have our surface markers, which are the ones that everybody uses. Here's our markers with the light chains and VS38C, and then lastly we have BCMA, and we'll talk about BCMA in a bit. And again, I am a firm believer in combinatorial gates and reducing number of plots. So what we can see here is that what the gating strategy that we use now in our lab is to use the VS38C and 138, as you can see here. And then this case, this patient had daratumumab, so the 3845 gate that is recommended by ICCS, you don't see reactivity. But because we're now using combinatorial gates, it doesn't matter because you'll still see it on the kappa lambda plot. So before we talk about BCMA, we'll quickly touch on some pitfalls. As you can see, this is a marrow from a patient who had myeloma and got daratumumab for it. And this is the marrow. The marrow actually showed this kind of weird, like 10 positive, kappa positive population. That is kind of weird. You're like, and that in this case, I think our technologist actually called me and said, like, hey, there's a weird kappa positive population. What is this? So if you look at the 20 and 20 versus 10 plot, or the 10, or like 34 positivity, you actually see that like this actually looks very much like a hematocrit pattern, right? You don't have the 38 anymore because of the DARA, but they're also negative. They might have a little bit of variable 34. And you're like, oh, this seems very suspicious for hematogones. So why are hematogones binding kappa? So if you recall, daratumumab is an IgG1 kappa antibody, which basically means, if you looked at the 19 versus 38, you actually see that hematogones actually express quite a bit of CD38. So what you end up seeing is that the daratumumab will actually bind to the CD38 on hematogones, and because this is a B cell too, you add on the anti-kappa antibody, and which will actually act more like a secondary antibody. So it's actually going to bind not to the CD38, but it will actually bind to the kappa of the daratumumab. So you'll see this a very characteristic kind of a pattern where you will see this kind of almost kind of very flattened, very homogeneous expression of the population that is expressing kappa. And this is a known artifact, and it's important to not call this as an abnormal population because, again, this is purely artifactual. So now we can talk about BCMA. I know a lot of people are trying to bring up BCMA by flow cytometry or by IHC. Here, it actually works BCMA works pretty well in terms of as an IHC antigen. You can see compared to 138, it actually looks very similar. A lot of times it's not quite as crisp as CD138, and the staining can be a little variable from cytoplasmic, Golgi, or surface, or a combination of both, all three. And by flow, we do surface staining by BCMA because again, we're using it just more for not really for detection, but mostly for antigen expression prior to BCMA immunotherapy. And as you can see, it's not very bright. You usually need it if you want to use it. You need to use it against another plasma cell marker like 138. And if you look at the histograms compared to other plasma cell antigens that are commonly used like 38 or 138 or VS38C, the resolution is actually not as good. So compared to background lymphocytes, so it's not great for a gating marker, and it's actually not that great for it doesn't work as well for flow. One thing that I also want to reiterate is that BCMA flow requires you to wash the cells. BCMA is a secreted antigen, so it's kind of like you have to approach it the same way that you approach a kappa lambda staining. So you have to remove anything that is in the serum to make sure that you don't deal with the hook effect. So if you're having trouble with it, I'm happy to share our protocol with you. But again, make sure you wash it. And you also need to use a very bright fluorochrome. Like we're using BB421. We tried PE and it didn't work very well. So, kind of summarizing again, for plasma cell neoplasms, the major thing is that you can use of intracellular antigens such as VS30AC or IR4 can be used more readily because you're fixing and perming them anyway. Daratumumab also has positive and negative artifacts. BCMA by flow, kind of questionable, but it can be done. It's a little finicky. But and then last but not least, I didn't have time to go over this because this was a talk that focused more on flow. But for patients who have received BCMA CAR T, there's actually a growing number of case reports where these patients develop a rare T cell lymphoproliferative disorder. Most of these cases actually happen in the GI tract, but it is also something. So you may not see it by flow, but it is something to kind of be on the lookout for. So lastly, we'll go through a challenge case. So most of this talk has really been focusing more on the B and plasma cell neoplasms, but there's actually, immunotherapies for myeloid neoplasms, T cell lymphomas, and other things. So I'll show you an example of that. So this is a patient with a history of, well, obviously very bad BPDC, and you can see blasts everywhere in the aspirate. It's also circulating. The BPDC is positive for 4 and 56 and very bright for 123. So in addition to all the things that we've talked about, there's other antigen immunotherapy therapeutic targets. One of the other targets is 123 using a fusion protein for a word that I cannot pronounce. But this patient got the anti-CD, the CD23 fusion protein and received 3 cycles of it. Unfortunately, he didn't respond to it, as you can see, based on the 56 and 4. But what you can now see is that there's now a distinct subset that shows CD123 loss. You're like, great, this patient didn't respond, and now at least about half of them are now lost CD123. So if you were just focusing on this stuff, you would miss all of this stuff. So again, you can't use 123 to gate for plasmacytoid dendritic cells anymore. And then what was interesting is that the clinicians were like, hey, we're running out of options. Are there any other markers that we can actually think about using? What about 38? I was like, well, they are positive for 38. I can tell you that because plasmacytoid dendritic cells are usually positive for 38. So they said, oh, great, we will use that. So this patient was started on decitabine, venetoclax, and daratumumab. And unfortunately, that didn't work very well either. You can still see the bimodal population, but plenty of disease. And because this patient also may have had there was worry about a concurrent CMML. We also wanted to make sure there weren't any weird blasts or anything like that. Except now, because this patient has gotten daratumumab, we've completely lost CD38 expression, which means that I can't tell if that 34 positive blasts are really normal or not using the 38-34 screening plot. But if you actually looked at this, 34 bright population, you actually do know that they are actually abnormal because they've downregulated HLA-DR and they've also lost CD33 expression. So this was also something that we need to watch out for, particularly if we're now going to be growing the number of immunotherapy targets and and if they were ever using CD38 and you're worried about blast analysis. So that was a problem. But this patient was then switched to hyper CVAD, got into clinical remission, complete remission, although he was MRD positive, so got transplanted. But unfortunately, he did relapse after 6 months. And this is the CSF, and you can see lots of blasts everywhere. And then, because it's been a while, it's been over 6 months since the last daratumumab, you see that the 38 came back, but the 123 still remains bimodal. It's been over a year since he's gotten anti-123 therapy, which raises up questions that are yeah, we may be using multiple things, and some things may come back, some things may not, and you need to kind of keep track of all of this when you're assessing for recurrent disease. So takeaway points. So, well, the moral of the story is if an antigen is good enough for diagnosis, there's a pretty good chance that someone out there is trying to make a CAR or some sort of therapeutic antibody against it, which basically means that we are in a arms race with the oncologists, because now we are actively, if they use it, we lose it. So antigen downregulation and masking is common. And as you can see, it's happened for all the different diseases that we talked about today. It also happens with T-cell lymphomas. Basically, this is a common mechanism or a common problem of immunotherapy, and which means multi-parametric panel design is key with and you may also have to do more higher antibody titers to increase the sensitivity of these antigens. And then the antigen loss may be transient or permanent depending on the type of therapy and the antigen in question. There's not a lot of data on how well these things are panning out. So again, you can't rely on these antigens anymore. And then on top of that, not only is detecting the population harder, you're now also starting to see weird, artifacts and weird populations that you weren't used to seeing coming up that you have to really kind of keep track of, which means that it's not hard, but it's just there's just a growing number of things, pitfalls that you need to be aware of. Lastly, again, patients may receive sequential or combinatory immunotherapy regimens, which means that this problem isn't going to go away for us in terms of detection. It may actually get worse. So it would be important for us to keep that in mind, and really, if anything, really, we may actually start relying even more on the 4 side scatter and 45 side scatter, like the basic plots, because those will not go away. We may end up using more intracellular antigens, additional processing and other. There's a lot more that may happen in the future. And with that, thank you for your time, and I'm happy to take any questions.
Thank you, Dr. Jean, for such a lucid talk, and you have covered all the possible immunotherapies that can be given, the pitfalls that we can see, and beautiful cases, really beautiful cases. And I'll request and we have almost around 200 people who have joined from 2 links from India and across the globe. And audience, please put in your questions in the chat box. And meanwhile, I'll ask one.
Okay.
Okay. For BALL or BNHL, when we give CAR T, anti-19 CAR T therapy, so we expect that there will be B cell aplasia, right?
Yeah.
So, do you have any, the protocol for B cell aplasia monitoring in your institute where you get samples for B cell aplasia, and how do you do it?
So the B cell aplasia question actually came up even so when we have also do our reporting for our BAL or MRD, our clinicians have actually requested that we report out the percentage 19 positive overall for the marrows. They often run like the routine TB and K assays in the peripheral blood as well. So I don't really know the actual frequency, but those usually go through, they're not reviewed by a pathologist, so we don't see them as like frequently.
So because we get after CAR T, we get at 30 days, 60, 90 days, and then 3 monthly we get the request for B cell plasia. The problem which I'm actually trying to highlight is that if we do MRD in such cases and the B cells are not only there, by 19, 20, 22 combination. So
Mhm.
is there any minimum number of events of B cells you are looking for to say whether, to confidently report it that is this negative, or the B events are not enough to comment that it is negative? So something like that, because this is a practical challenge that, we have faced in our laboratory where the B events are just 200 or, 150. So our clinicians ask, is it enough that you're confident it is that event is definitely negative, but is it enough to call it confidently that it is negative for MRD?
So the MRD, the number of events that we usually use for a cutoff is, 100 for quantitation. 100 events for quantitation, that's pretty standard. That being the case, we actually go down, even if it's like, like 20 events, we will probably say that it's a rare population. We may not be able to quantitate it, but we know that it's probably positive. Um, Below that, I know for like myeloma and MRD, they may go down as low as 10. That for BALOs, it's if it looks like a tight enough cluster, then we may be able to call it. But other than that, it then becomes a little sketchy.
And we recently had a case of anti-BCMA CAR T, a patient of myeloma that was given anti-BCMA CAR T, and after that the patient had relapsed. So
Mm-hmm.
we ran BCMA, surface BCMA. We have it on PE, and we
Mm-hmm.
ran it on the flow, and we got a very dim expression of
Mm-hmm.
BCMA. So I got to know from your talk today that okay, we do get this dim kind of a BCMA.
Yeah.
So, okay. So, is the percentage of plasma cells expressing this BCMA important, or is it the expression, the bright, dim, or moderate that is because they want to give, teclistamab to this patient, the BiTE therapy. So that is where
Yeah.
they're concerned about BCMA persistence in this patient.
Yeah, we have the same problem. So generally, the percentage positivity isn't as reliable because again, like the whole thing about percentage is that like you don't know what to use as your threshold, right? And like we usually use T cells as our internal negative control just because like it's there and I know it'll always be. But but our clinicians actually don't really per se for most intents and purposes because it is so unreliable. They actually prefer to go more with like an actual antigen quantitation, but um there's no clear threshold like cutoff for any of our immunotherapeutics.
Okay. Okay. So we have a question from Dr. Sanjeev.
Mhm.
Uh, Excellent talk and thanks a lot. And what is the
Mhm.
proportion of your cases of BALL who had 19 positive relapse after 19 CAR T?
I think the relapse rate for it's actually similar to what's been published in the literature. So it's about like what 30 or 40% that are 19 negative. So I guess it's 100 minus that. So it's about like I think it's like yeah 60, 70-ish percent. But it is yeah, so that's yeah, I would say it's very similar to what we saw in like the in the literature.
Okay. So I have another question.
Mhm.
So post blinatumomab and post anatuzumab, the patient has been given both. So is
Yeah.
there any different strategy you would like to follow because 19 gone, 22 gone?
Yeah.
So
Sometimes like we actually just Cleargate and hope if it has CD10, then we may be able to we'll be able to like use that and to track it instead. And 24 may still work again unless it's like KMT2A or something. But we haven't had that many cases fortunately because our clinicians tend to avoid inotuzumab before they give CD19 CAR. But it can happen, in which case I actually recommend that instead of even just doing the 24-22 gate, just draw a broad PPM, like mononuclear gate, and just exclude the neutrophils.
okay, okay, okay. And do you see B cell aplasia post blinatumomab also?
Yes.
The B cells completely gone,
Yeah.
right?
Yeah. So like yeah, but it's also funny because like even for like blinatumomab or CAR Ts, like not some patients have prolonged B cell aplasia versus people there are patients who actually have B cell regeneration. And there is like a question it's like, well, what do we do with these patients and should we be monitoring them more versus not? We haven't had a good we don't really
Yes.
have a good answer to that.
Yeah, because we also get them for monitoring,
Yeah.
and if there is a slight increase in the B cell number, then the question which we are also have to answer is then what to do, how much to
Yeah.
monitor, what should be the frequency and
Yeah.
also. So I guess there is no clear answer to that as of
Yeah,
now.
there's no clear answer, unfortunately. So we're on the
Uh,
same boat. Yeah.
Okay. Okay. And anything, audience, any more questions for Dr. Jean? Otherwise, I'll keep asking.
Okay.
So in your KMT2A case, which you showed,
Uh-huh.
where there was a lineage switch and
Uh-huh.
45 10 34. In BALL, otherwise also in MRD monitoring, we see the myeloid progenitors and the precursor
Mhm.
cells.
Yeah.
So in all KMT2A, you will recommend to put myeloid markers also, or there was something special because 38 34 was the only thing.
Yeah.
So how to?
Yeah, so we always like in our analysis panels, we always screen the basic, we draw a basic blast gate, right? The routine blast, like 45 base gate and look at 38, 34, just to make sure that things are actually what it's supposed to be. And then for the 34 component, we look at like 19 versus 10 in our plots, just so like we can at least estimate if there's something odd about the blast populations. But for KMT2A, we routinely run the
Okay.
myeloid tube too. Yeah.
Okay, okay. That's okay. Okay. And I'll really like to know your BCMA protocol, because
Yeah.
as the bite and anti-BCMA is going to increase, it's going to be a painful thing.
Yeah. I
We
heard
use it.
yeah. Yeah, go
Yeah,
ahead.
sorry, please continue.
Oh no, I mean like the BCMA, the flow is actually not that great, but again, I see works better, but at the same time, you're like, I don't know how reliable it is because you see all the cytoplasmic staining. So you're like, I don't know what that means. I know like I think a pen they do BCMA by cytoplasmics, which I also don't know if that's as relevant because again, you only really care about the things that are on the surface, right?
And CD38 multi-epitope versus 219339,
Mhm.
the
Yeah.
other markers. So is there any
Yeah.
comparison that has been done?
The 219, I think we tried 219. It was 219, I think MSK uses it, and then they liked it, but it's also very dim. So we actually ended up not going with it because at that time the car was still in very early development, and you also need it with like another marker to kind of like tease it out. It's almost like, BCMA and that it's very dim.
Okay.
Um, Another thing on the myeloma market that people have been talking about more is GPC5D because there is an FDA approved immunotherapeutic for that. We looked around for that, but there wasn't a very good clone for that in terms of like for flow, so we haven't really launched it yet.
Okay. Okay. So for DARA cases, we basically rely on 38 multi-epitope. And
Mm-hmm.
so far it has worked really
Yeah.
nice. So do you recommend to combine it with those intracellular markers, the
Yeah.
IRS membrane?
Yeah. So intracellular markers we often do. Actually, sorry, I'm getting yeah, so we always run the intracellular markers because like I mean it's a little squirrely, but I'm just like we're already doing kappa lambda. It's just easier to just have one that you know will largely work because it's yeah, because the other ones really kind of come and go. Even 138 can be kind of fickle. So
Yeah, yeah. Okay, so we have another question from Dr. Sanjeev that in KMT2A cases with B and myeloid markers, do you consider or sign out MPAL in absence of MPO? You know,
uh that's
you're running
the whole like
mRNA.
yeah positivity of MPO for MPAL is squirrely at best. So it's very but I we usually don't sign it out without MPO. I mean that is a diagnostic criteria. How that threshold gets set is really kind of problematic, but yeah, you technically need it.
Yeah, but in your case, it was 1333 was negative, but there was 64 gaining, 4 was there. So
Oh
if you have
yeah.
monocytic markers, then
Yeah, it'd
all.
be, I mean, like that one, I would just, those ones that we usually say, like, because this is also a recurrence, and this is a lineage switch, not like, like the MPAL kind of like, true MPAL kind of diagnostically, we don't really run cytoplasmic MPO in those kind of cases, because you're like, well, you know what this is actually is, and it's KMT2A. Okay.
So if there are no more questions,
Mhm.
then thank you, Dr. Jean. It was a privilege to have you here and to listen to your wonderful talk. It was really very exciting, and I at least learned a lot from your talk,
Okay.
and hope to collaborate. And
Uh-huh.
in future, let's more. I would like to listen to more of your talks, and we can even
Mhm.
work together for certain upcoming ideas.
Okay, great. Thank you for inviting me. All right.
Thank you. At the outset, I'd like to thank all the participants who have joined and made this a success webinar. And thank you, Genova, for supporting this webinar, the Zoom meeting, and all. And good night, everyone. Thank you so much.
Great. Thank you.
Thank you. Thank you.